In this section, we'll take a look at the basic anatomy of the lower respiratory system. So the first slide here again is one of these anatomy summary slides that I would like you to know everything in these slides that have this banner. It's not a lot, but it's basic in these slides. So we've already talked about the larynx, we've talked about the trachea, and here's the bifurcation between the primary right and left bronchus, and then we're just following the left one. The right one does essentially the same thing, and what we're looking at is basically a branching bronchial tree. It's upside down. So the trunk is up in the air, and then the small branches and basically the leaves that are analogous to the alveoli are upside down. But the idea is the same. The airways get smaller and smaller and smaller until you get out to the alveoli, which is where the respiratory membranes are. For gas exchange. The analogy of an upside down tree works pretty well because on a tree the membranes for gas exchange are the leaves. That's where they take in carbon dioxide and release the oxygen. We do just the opposite. So we'll be looking at the bronchioles in particular. So on the right is one of these alveolar clusters that's enlarged, and a couple of things to note on this slide are the bronchioles, and those are wrapped with smooth muscle that's shown in brown, and a branch of the pulmonary artery is also shown. So we have airways and capillaries meeting for the gas exchange. And notice that along the bronchiole, which is on the left, there's a bronchial artery, a bronchial nerve, and a bronchial vein showing. So this is blood supply that is feeding the bronchiolar smooth muscle. This is not blood that's going down to the pulmonary capillaries. This is a separate blood supply. So let's say this supplies the bronchiolar tissue. For example, the bronchiolar smooth muscle. There are abundant elastic fibers, and those are wrapped around the alveoli that have to stretch when the lungs inflate. And here is a branch of the pulmonary vein. It's red because it's been freshly oxygenated. And here are the pulmonary capillary beds shown. So it's good to sort of ponder that figure and take a look at it in detail. Lymphatic vessel, and then here are the alveoli, which are the tiny little air sacs. They look like little grape clusters. And the next slide looks at those in more detail. So again, know it all. So what we're looking at on the left are several alveoli for the gas exchange, and there are type 1 alveolar cells, and type 1 alveolar cells are for the gas exchange. So the gas exchange occurs across the membrane. So in this figure, this open area of the alveoli, here is a blood capillary. So the gas exchange is occurring across here. So oxygen is going in and carbon dioxide is coming back out. So it occurs across that thin little membrane, which is shown over on the right. So those are the type 1 cells. So most of the cells that you see here are all type 1 alveolar cells that make up the walls of the alveoli. Type 2 alveolar cells, different function. These cells produce surfactant. And surfactant is a film, it's a liquid that's produced by these cells, and it goes out onto the surface of the alveoli and reduces surface tension. So that's the role of surfactant, is that it reduces surface tension. If you remember from Biology 160, we looked at how water was basically sticky from the hydrogen bonds. And at this small scale, with these thin membranes of the alveoli, the membranes would tend to get stuck together, just like two pieces of plastic bag that get stuck together when they have water between them. So surfactant reduces that surface tension, it breaks the hydrogen bonds, and allows the lungs to inflate more easily. Reduces surface tension, let's say, by disrupting the hydrogen bonds. H bonds of water. That's necessary for the lungs to stay inflated. One of the problems with premature babies, if they're born very premature, their lungs have not had a chance to develop, and they're not producing the surfactant. Normally their lungs wouldn't be expected to work at that early stage of development, but if they're born too early, they don't have the surfactant, their lungs have difficulty inflating, and if they survive, they tend to have compromised lung function for the rest of their life. The figure on the right is just an enlargement of this respiratory membrane again. It's just enlarged. And so what we're looking at is, here is the alveolar space. So we're inside the alveoli. And here we're inside the blood, plasma, and a red blood cell. And we have a thin capillary layer of the endothelium, and we have a alveolar cell. This would be a type 1 alveolar cell. And the surfactant is on the surface. And the surfactant again was made by the type 2 alveolar cell. And this is the respiratory membrane. The blue arrow is showing the exchange, or representing the exchange of gases back and forth. So oxygen is going in to the blood, carbon dioxide is coming out of the blood. Next slide. Larger view of the lungs. Note that on the right lung, right and left, there are 3 lobes. Three lobes on right. And we have a superior lobe, a middle lobe, and an inferior lobe. That's how they would look in an anterior view. The apex is at the top, and the base is at the bottom, sitting right on top of the diaphragm. On the left side, have a superior and an inferior lobe. So there's only 2 lobes on the right. And the heart is smushed over off midline, compressing bit of the left lung, and that space in the lung is referred to as the cardiac notch. The heart fits in there. There's the heart. And it pushes off into the left side. Rather bad drawing of a heart. There, that helps. 4 chambers. On the right side of this figure, we're going to spend some time looking at the pleural membranes. Note the spelling. And we'll talk about the pleural cavity between the 2 membranes. We'll come back to that later. This slide shows the details of the blood supply to the alveoli. There are 2 blood supplies. The major one is the pulmonary circuit. So in blue we have the pulmonary veins, a division of it, branch of the pulmonary veins. They basically follow the bronchioles coming in, and they supply pulmonary capillaries, shown near the bottom. Gas exchange occurs, and then blood leaves through the pulmonary veins, which go back to ultimately to the left atrium. And then to the left ventricle and back out. I put a box here to remind you of the other much smaller blood supply into the lungs, which is the bronchial arteries. So read the box. It says, note, small bronchial arteries that branch directly off the aorta supply the bronchial nerve tissue and the smooth muscle. And what's interesting, if you follow along here at the very top of the figure, there's the bronchial artery shown by the black arrow. It then supplies capillaries, which are shown on the surface of the bronchiole. So I'm going to draw those in yellow. Doesn't show up all that well. Maybe I'll do green too. So there are these bronchial capillaries. So all that we're doing is just supplying the smooth muscle, etc. But watch where that blood drains. So this is arterial blood that supplies those capillaries. A significant amount of that blood, which is a small volume to begin with, granted, it exits, drains those capillaries, and merges back with the oxygenated blood in the pulmonary veins. So this is low oxygen from this bronchial circuit. The bronchial supply came in oxygenated right off the aorta, supplied the tissue of the bronchioles, drains out of those bronchial capillaries, and merges with freshly oxygenated blood of the pulmonary circuit, which tends to dilute it a small amount. It's interesting that you have those two blood supplies, and that's how it drains. Some books will show the oxygen content of the pulmonary veins being reduced slightly due to the mixing of this deoxygenated blood. And this slide shows a number of things. So again, on the far left, it shows this upside down branching bronchial tree. So one thing to note is that in the upper passageways, there's a good deal of cartilage, which holds the airways open. If you can't see what's in that box, it says cartilage. So those are the blue plates. In the trachea and the primary bronchus, those were rings, cartilage rings. And further on down, as you go deeper into the tree, the cartilage becomes less and less until now what predominates is smooth muscle. So there's been this transition of tissues. And the upper airways that are dominated by cartilage do not bronchoconstrict. So no constriction at this level. They can't. The cartilage is holding the airways open. They can be plugged with mucus if they become inflamed, but the bronchioles further down that are dominated by smooth muscle are able to constrict and dilate. Bronchoconstrict / dilate. That's the smooth muscle. The smooth muscle either contracts or it relaxes. So, before we get to the boxes on the right, in the middle is the terminal bronchiole again, and just note the smooth muscle. It's the brown fibers wrapped around the airways. Lots of smooth muscle. I'm abbreviating muscle, just M. The other thing to note are the elastic fibers, which are shown more or less in green. We'll come back to those later. But the elastic fibers are sort of forming a mesh around the alveoli. The alveoli literally have to expand and contract. So you're literally inflating like a rubber balloon and then letting some of that air out. So it's inflating, deflating slightly. Okay, the two boxes on the right are looking at or describing the control of the smooth muscle. So let's start with the parasympathetic system on the top in the blue box. So the parasympathetic, going to the lungs, going to the bronchiolar smooth muscle in the lungs to be specific, is carried by the vagus nerve, which is cranial nerve number 10, if you had to learn that in A&P 1. If you didn't, don't worry about it. But these are cholinergic neurons, and they use a cholinergic receptor. So cholinergic, of course, is referring to acetylcholine, ACH. And the cholinergic receptor is a muscarinic receptor. And that stimulates smooth muscle contraction. And that leads to bronchoconstriction. So the bronchiolar smooth muscle contracts, narrows the airway, we have bronchoconstriction. That's parasympathetic. Sympathetic nervous system, you remember, is has sort of the opposite effect of the parasympathetic. So if the parasympathetic bronchoconstricts, the sympathetic is going to bronchodilate. So it's regulated by the smooth muscle, so you need to cause the smooth muscle to relax. So, a couple of things to note. There are beta-2 receptors in the lungs. We keep harping on that. Specifically, those beta-2 receptors are on the bronchiolar smooth muscle in the lungs. Now, there are no nerves to those receptors. There are nerves to the muscarinic receptor or the parasympathetic, but the sympathetic doesn't innervate beta-2 receptors. The sympathetic nervous system innervates beta-1s, and sympathetic innervates alpha receptors, but not beta-2 receptors. So beta-2 receptors are stimulated by epinephrine primarily, and some norepinephrine from the adrenal medulla, and those travel through the blood. So they're acting as hormones. They bind to the beta-2 receptors and cause relaxation of the smooth muscle, which leads to bronchodilation. The next slide gives you an opportunity to practice that. So in this slide, what I'd like you to do is to pause the video in just a moment and complete this diagram. So draw in some sort of airway, some sort of bronchial tree. There's a trachea. This is good enough for now. So there's some branching airways. So trachea, and then primary and secondary bronchi, etc. That's enough. And then put in some smooth muscle. So, pause the video and put in the regulation, parasympathetic and sympathetic regulation to that bronchiolar smooth muscle. Include the neurotransmitter and the receptors and the response. So I'll give you a moment to do that, and when you're done, restart the video and we'll finish it together. Okay, let's finish this, and let's do the parasympathetic. So we'll just pretend that this is our second neuron, our postganglionic neuron. So this is a parasympathetic. I'll abbreviate parasymp for parasympathetic, and it is a cholinergic neuron, which just means that it's going to be releasing acetylcholine. So ACH is exocytosed out of the axon terminal from last quarter. And then we will put a receptor, doesn't matter what shape it is, but we need to call it a muscarinic receptor. And when this pathway dominates, ACH binds to the muscarinic receptor, and the response is contraction of the smooth muscle. And that leads to bronchoconstriction. For the sympathetic response, let's use the other side. So here comes epinephrine and some norepinephrine. Most of what comes out of the adrenal medulla is epinephrine. So it's coming through the blood. And let's say from the adrenal medulla. And the receptor that we have is a Beta2 receptor. So there's our Beta2 receptor on the bronchiolar smooth muscle. So it has both receptors, both beta-1 and muscarinic receptors, and that binds to the receptor, and the response is relaxation of the bronchiolar smooth muscle. Relaxation of smooth muscle. Abbreviate muscle, and that leads to bronchodilation, opening the airways. Later, when we'll look at asthma, and well, the next slide actually, and talk about a couple classes of medication. So let's do that last slide now. And so I've sort of summarized a couple of things that I'd like you to remember. So when we're talking about asthma, patient with asthma, and you're trying to control it, strategy, there are basically two approaches to controlling the asthma. One approach is to maintain it and prevent the asthma from flaring. So you're trying to reduce inflammation, because asthma is an inflammatory response where the airways become inflamed and they start to secrete mucus, they bronchoconstrict, and it is an inflammatory response, and over time, if it's not managed well, scar tissue eventually infiltrates the bronchial airways, and then you have lost, or the patient has lost, the ability for them to constrict or open up. So in order to reduce the inflammation, aside from trying to identify the triggers of what's causing it to begin with, the inhaled glucocorticoids are the treatment of choice for preventing asthma. They're sometimes referred to as the gold standard for prevention. Best practice are inhaled corticosteroids, and these are typically taken on a daily basis. They're inhaled, they are a corticosteroid, but they're inhaled, and there is very little of the medication that gets into the systemic circulation. Being inhaled, it tends to stay directly in the lungs, on the lung tissue, and does not circulate in the systemic circulation to a large extent. A couple of examples of inhaled corticosteroids are Flovent and Qvar, trade names. So it would be good if you recognize Qvar or Flovent as an inhaled corticosteroid to prevent asthma from occurring, to try to control it. The other approach for, or the other class of medications for the control of asthma are the rescue medications. And these are used when you have an attack, which is an indication that the prevention and the maintenance isn't working. And when an asthma attack occurs, the rescue meds act as a beta-2 agonist. So agonists stimulate receptors. So a beta-2 agonist stimulates the beta-2 receptors. And since you know what that does, when you stimulate a beta-2 receptor with norepinephrine or epinephrine, here we're doing it with a different drug, that leads to bronchodilation. So it leads to relaxation of the smooth muscle. A couple of examples of beta-2 agonists that I would like you to recognize. Albuterol is a generic, trade name Ventolin, Proventil, etc. But albuterol is what it's commonly referred to as. So I would like you to sort of appreciate the treatment and the maintenance of asthma with maintenance medications and rescue medications. These should not be used, ideally, these are not taken daily. So if a patient is relying on albuterol all the time, what that should tell you is that they're not maintaining, they're not controlling the asthma. You're not controlling the triggers, you're not controlling the inflammation, damage is being done in the lungs. So they need to try to tamp down the inflammation, identify the triggers, avoid them, and start taking and maintain the inhaled corticosteroid use. Okay, that's it for this unit.